Today we are going to talk to you about the artificial larynx. I'm.
And I'm.
Prior to the early 20th century, there were experimental devices in certain academic settings. Due to their impracticality and poor usability, it wasn't until the late 1920s that these devices were widely utilized. This is when the first recognized electrolarynx was developed by the Western Electric 5A company. The electric revolution came underway during World War II. A more advanced electrolarynx was produced. With the advent of the transitor, these devices became much smaller, and finally a portable electrolarynx was created by Bell Laboratories in 1959. In 1980, the Cooper-Rand electrolarynx was developed, being one of the first intraoral electrolarynges, and it is still available today. Modifications and advances in the electrolarynx design have led to the current available electrolarynx being smaller and more portable and completely handheld. Those who qualify to receive an artificial larynx have had a complete laryngectomy as a result of laryngeal cancer. This type of cancer can include the larynx, supraglottis, glottis, subglottis, and possible surrounding structures.
There are two main types of artificial larynges or ALs, the pneumatic AL and electronic ALs. The first type, pneumatic AL, is produced by Tokyo Pneumatic Artificial Larynges and available for purchase. However, they're not common in the United States. They're more widely used in South and East Asia, where languages have linguistic markers of pitch and intonation which alter semantics and expression. Pneumatic ALs utilize pulmonary air as its power source. A cuff that contains a reed or a membrane fits over the stoma, and as the patient expels air for speech, a flexible rubber or plastic tube placed into the patient's mouth transmits the vibration from the reed. The patient then articulates normally. The advantages of the pneumatic ALs are that sound quality may be more pleasing than the electrical device because there's no electronic feedback or buzzing. The disadvantages are that the tube must be in the mouth during use, which may interfere with articulation and cause excess saliva. And like any stoma cuff, it may become clogged with mucus and requires daily cleaning.
Neck-type devices, such as the TrueTone, are the most popular of the devices. The sound source comes from a diaphragm in the head of the instrument. This is set into vibration when the speaker presses the on and off button. The device can be placed on the side of the neck, under the chin, or on the cheek. This allows the sound to be transmitted into the oropharynx through the tissue. The user can create variations in pitch and volume through manipulation of the switch on the device. This device is typically used for patients who cannot get adequate sound transfer on the skin. An example of this device is the Cooper-Rand, where the sound is transmitted through a plastic conduction tube. The user places this tube 1 to 1.5 inches in the mouth and on the top of the tongue. The tube should enter the mouth at midline or from the corner of the mouth at a diagonal angle. Most of the neck devices can actually be converted to an oral device by placing a rubber or plastic adapter on the head. An oral device is ideal for those who have extensive scar tissue or edema of the neck. This device can be used immediately following surgery. Like with the pneumatic device, a disadvantage is that the plastic tube can often interfere with articulation. The Ultra Voice Plus 2 is an intraoral device that is custom mounted into a denture or a retainer. Inside the device is a built-in loudspeaker and an amplifier with a flexible membrane. This is there in order to protect the device from food, saliva, and other liquids. This device consists of a lightweight unit mounted into the acrylic denture, a high-speed signal processor control unit, and a charging unit. An advantage of the device is that it allows the user to closely mimic the natural voice by controlling the loudness and prosody. A disadvantage is that it can be costly, but may be the only device a patient can use.
Speech pathologists' main goal of therapy will be to increase intelligibility. The focus of treatment will be on articulation, placement, proper seal, coordination of movement, and limiting stoma noises. Pathologists should encourage their patients to use a technique called the big mouth effect. The user should over-articulate without becoming too exaggerated. The Patients who articulate with little oral movement are difficult to understand. Over-articulation will also help open the vocal tract and improve resonance. SLPs also educate and practice the technique of using intraoral air for articulation and voiceless sounds, as well as coordinating the on-off switch of the device for onset and offset of voice. Here's the electrolarynx without big mouth effect. Here's the electrolarynx with big mouth effect.
Rocky Mountain University.
Do not do over-exaggerated movements.
Rocky Mountain University. Placement.
Speech pathologists should experiment with various placements of the device to find the best possible sound transfer into the oral cavity. These placements typically include the neck, cheek, and under the chin. The SLP will instruct the patient to count while moving the device to these various locations. The best placement site is typically under the jaw and slightly off midline of the neck. The cheek may be another optimal place if the patient has thick neck tissue. In the next clip, you'll see the SLP practicing placement. I'm going to have you count to 3.
The SLP will then have the patient practice proper sealing by placing it on the palm of their hand. You will see this demonstrated in the next video.
So the first time I want you to put it tightly close to your hand. Now this time you're going to slightly have it off.
Developing conversational speech.
Have the patient practice finding their sweet spot quickly and accurately, at first using a mirror or by marking the site with a sticker or piece of tape. Have them then place the device and say short phrases and sentences or respond to questions. Once consistent with placement, expand tasks to conversational speech. Discourage the use of monotone robotic speech. Practice natural intonation, pauses, and steady rate, all while reinforcing coordination of on-off activation and sound generation. Here's a patient practicing finding the sweet spot. I want you to practice consistently and accurately finding your sweet spot.
Okay.
Coordination of movements.
The SLP's responsibility is to teach the patient to remove their device from their neck when they're not speaking. This is important because oftentimes they have a habit of leaving the device on or near the neck during conversational speech. Teaching this technique will help them with better flow of speech by signaling that they have something to say, much like us taking a breath before we speak. Without taking the device off of their neck, you'll see interrupted flow of conversation.
I just have to go to the store. What are you gonna do? Oh, that'll be. Oh, sorry.
During this conversation, you'll see a better flow because the individual is actually pulling the device away from their neck when they are not speaking.
I'm just gonna go play with Tim's birds. What are you gonna do? Oh, that'll be fun. Who are you going with?
Stoma noise.
To eliminate or reduce the amount of stoma noise, you will teach the patient to mouth the words and not whisper them. The patient should practice reading phrases by just mouthing the words and at the same time monitor the amount of stoma noise being heard. The SLP will also encourage the individual to discontinue whatever non-oral means of communication previously used. Once more the stoma noise is eliminated, the SLP can start talking to the patient over the phone during therapy sessions to assess intelligibility.